Roundtable on. There we go. I'll do it again. Welcome to this roundtable on learning from epistemic injustice and global health. I'm Michael Bresalier, and I'll be convening the roundtable. The roundtable comes out of a larger Wellcome-funded project on epistemic injustice in healthcare. And what I'm going to do before we get into the roundtable is hand over to the principal investigator, the PI on the project, Javi Corral, to say a few words about EPIC. Over to you, Javi.
Thank you so much and welcome everybody. This is really wonderful. We've got 50 people on the Zoom and more joining. So I'm delighted to welcome all of you to this really important stream in our project that Michael is heading with interest from another one of our co-Is, Ian James Kidd. And what we will be doing this afternoon is taking the themes of epistemic injustice and in healthcare and applying it specifically to the really significant area of global health. And it's particularly wonderful to be seeing lots of people from lots of different places joining us. So EPIC is a 6-year project funded by Wellcome. It's a discovery award, and it's aimed at tackling questions of how to improve healthcare and how to reduce the harms that are caused specifically by problems in, if you like, the belief economies or the credibility economies within healthcare. So this could include the ways in which patients' testimonies are disbelieved or belittled or not acted upon, but it can also include the range of dynamics within healthcare professionals in their complex hierarchies, and of course between other players, if you like, in the epistemic domain, such as caregivers, family, and so on. So without further ado, I'm looking forward to this interesting discussion. And as Michael said, 2 things to note. First is this will be videoed and then placed on the EPIC website. And the second is to really invite you to be sorry, there's lots of people entering, to be in touch with our project. We're very, very interested in creating and sustaining and nurturing our international connections. And Michael will say more about his contacts in North America, Africa, etc. And we'd be really pleased to hear from anyone who wants to connect with our project. So over to you, Michael.
All right, thanks, Javi. That's great. Let me just quickly say something just about the basic format of the roundtable. So we're going to run for about 50 minutes, maybe 60, well, 50 odd minutes. I pre-circulated some questions to the panelists, and that provides sort of a basic skeleton for the discussion, but it's going to be quite, well, hopefully it'll be quite wide open. And then after the 60 minutes, we'll move to questions and answers or comments for about 30 to 40 minutes, depending how time permits. So we're scheduled to end for 1:30. If you have a question or a comment, please put your name or your question in the chat. We'll try and keep track of the questions and the list of people going forward. And ideally, you did then in the Q&A session, just unmute yourself and ask your question, or one of us can read it. So let me just sort of briefly introduce the roundtable theme, and then our panelists, our speakers. As you all know, global health itself is in a perilous place at the moment. There's no need to rehearse the reasons why. There are many and manifold. Now is also a time that many deeply rooted structural issues in global health are being reflected upon. Now, again, as you all know, one of the paradoxes of global health is that, while it's long been aimed at tackling health inequalities, health injustices, its very structures often produce or perpetuate these very inequalities and injustices. People have been addressing this paradox in various ways for a long time. But a relatively new focus, at least in terms of how it's been formulated, is the problem of epistemic injustice in healthcare, or in the words of one of our panelists, unfair knowledge practices or systems and their consequences for particularly marginalized people and communities in different parts of the world. Now, of course, inequities in the production, access, and sharing of health knowledge have been a concern in global health for a long time, from the get-go. But approaching such inequities through the lens of epistemic injustice provides, at least the the assumption here is that it provides a potentially valuable new ways for understanding uh, injustices and inequities, and ideally also for addressing and ameliorating them. This brings us to today's the purpose of today's roundtable. One purpose is to share and reflect upon the various different and important work that's being done on epistemic injustice and global health as parts of trying to make global health more just, more equitable, fairer, and so forth. And the second aim, which ties into the EPIC project in particular, is to highlight and try to consider what can be learned from such work to address epistemic healthcare more generally in healthcare. So, like, in what ways can epistemic health work in global health provide ways of understanding unfair and unequal knowledge and practices and structures in health systems and settings more generally? So, with that preamble, and that's about as much as I'll end up saying, hopefully, through for the remainder. We're really lucky. We're very lucky to have a wonderful panel to take us through and tackle some of these. These are very big issues. They'll say a little bit more about their work and experiences in a moment, but let me briefly introduce our roundtable. First of all, we have Rageshri Dhairyawan, who is a consultant physician in sexual health and HIV medicine in London, and author of a wonderful book, Unheard: The Practice of Medical Silencing. Hello. You can put your hand up. That'd be great to see, because we have a lot of people. Um, we have Seye Abimola, who is professor in the School of Public Health at the University of Sydney, whose most recent book is The Foreign Gaze. We have Linda Maqutu, who is an assistant lecturer in the Department of Philosophy at the University of Johannesburg. Thank you, Linda. And who's completing a PhD on epistemic injustice in AI and machine learning systems in mental health care. We have Himani Bhakuni, who is a lecturer in law at the University of York, whose research addresses, among many other things, unfair knowledge practices in global health justice, and rights-based approaches to epistemic injustice. And we finally have Ian Kidd. Where are you? Oh, there's Ian. He was associate professor of philosophy at Nottingham University, a co-investigator on the EPIC project, and, if I may say, one of the people who's helped really plow the field of epistemic injustice in healthcare. So that's our panel. If we were sort of in a room together, we'd be around a table or some sort of setting, but we're on Zoom. So what I want to do is to, as a start, is just to hand over to our panelists and roundtablers, and to have each say a little bit about how you came to work on epistemic injustice in global health and healthcare, and some of the problems you're addressing. So I can ask somebody to go for first, or somebody can volunteer. Who would like to kick off? Himani, great. Thank you.
Hi, everyone. And thank you, Michael, Harvey, and Ian for organizing this roundtable. So I'm Himani, and I entered the space of epistemic injustice and unfair knowledge practices primarily as a human rights lawyer. So after working as a human rights lawyer, I transitioned into academia, and my academic background is rooted in law and development scholarship. So we basically critically examine international legal frameworks from a global south perspective. So initially, when I was working in research ethics, it became increasingly clear that the exploitation that was happening in global health research wasn't just material, it was primarily informational. and intellectual and deeply intellectual. So, and the transition into explicitly using this framework came with my work with Seye. So when I started working with Seye, so he had been writing on I think by then you'd already written The Foreign Gaze and Global Health, and you'd probably also started working on unfair knowledge practices and uses of knowledge in global health. And around that time, we came together, we discussed all these issues, and we thought, why not use an existing philosophical framework for these issues, which was the epistemic injustice framework. And that's how, because what we were witnessing in global health were actually systemic issues, and they were distinctively epistemic wrongs, and that's how we came to it. So whoever goes next can introduce their work.
Say, since Himani just tied you into this in that way?
It is she did that on purpose. This is by design. She wanted to do this. To add one additional layer to it, I think part of the choice of epistemic injustice as a frame was also to be more specific in a sense, among many discussions that are happening in global health around decolonization. And there's a sense in which they overlap. I often describe them in form of as a Venn diagram where there's what is colonial and what is epistemically unjust. They overlap, but not fully. And I thought it was necessary to be specific about the epistemic dimensions of what is colonial, but also the epistemic problems that may sit outside of what we may readily call colonial. So it was a useful frame in a sense to specify a certain set of wrongs that were epistemic in nature, and that could give it a frame, a name that makes it easier to talk about, which itself is in the service of correcting an epistemic injustice itself. In other words, having a way to talk about this that allows discussions to be had, debates to be had, was itself, as we were thinking about it, Himani, trying to correct that wrong, because this is a splattering of wrongs that were generally, I think, harder to talk about together. And it was necessary, we felt, to talk about them together. And this level of framing helped us do that.
Great, that's great. Linda, do you want to come in next?
Yes, I think I can come in next after that great framing. My work focuses specifically, I was looking at, decolonization, and I was looking at the inclusion of African traditional medicine, specifically traditional healers in the context of South Africa, and their role in mental health care, and how, they could shape and, improve mental health care. How I came into epistemic injustice is that I needed to be able to name what this exclusion or what the problem was, that I was recognizing in terms of this exclusion of African traditional medicine, or this lack of sufficient inclusion of them. And then I became interested in the role of epistemic injustice within mental health care, but also with the rise of the use of AI to mitigate, to sort of diagnose and provide sort of help doctors to triage and diagnose problems in mental health care. And then I became interested in how there are colonial histories that shape what counts as like legitimate knowledge within healthcare and mental health care. And I wanted to examine how possible colonial histories can reproduce exclusions in terms of marginalizing indigenous knowledge systems like African traditional medicine, when they're included in machine learning systems. And so then that's how I came involved in epistemic injustice, and like this sort of claim that without decolonization we risk perpetuating, the same sort of issues of colonialism and, exclusion. And that's sort of how I came involved in epistemic injustice.
Great, thank you. Rageshri, do you want to come in?
Yeah, hi everyone. So I first learned about epistemic injustice through Twitter, now X, and I can blame my husband for it. So I had an irritating incident where I tweeted a list of racial health inequalities that had existed before COVID, and it was immediately dismissed by someone who didn't believe I had the medical expertise to be able to come up with such a list. And it was annoying. And my husband said to me, "Oh, I think you've suffered a credibility deficit there. I think you've experienced testimonial injustice." So I was like, what is this? So I did my research and I went on to write a blog which really looked at how epistemic injustice shows up in the workforce for healthcare workers and how that can impact on patient care. And that did quite well. But at the time, doing reading around the issue, I realized this is something that really massively affects patients. And this led me to read Ian and Javi's work. And then I wrote an essay about patient experiences and being dismissed. And I kind of thought that epistemic injustice would make a great framework to think about health equity and looking at it at different levels. So I went on to do the research for my book Unheard, which kind of looks at it from the consultation room to the healthcare workforce to research global health. And I really wanted to kind of foreground patient activism and think about kind of epistemic exploitation and how we can really listen ethically to people. So it's kind of doing that research where I came across Ian's work, Seye's work, Himani's work, which has been really useful for my theorizing. And I guess as a clinician, I wanted to really think about practically how can we use this conceptual tool and how can we address it.
It's great. And hopefully we'll get into some of the details of that in a bit. Ian, can you give us a little background story?
Well, thank you, Michael, and thank you all of you for making the time to be here today. My interest in epistemic injustice began exclusively through Harvey's work on philosophy of illness. One of our shared concerns is to get philosophers more interested in illness. And during an auspicious conversation in a pub, we had the question of what would be the agenda of the discipline of philosophy of illness. And one of the concepts we mentioned was epistemic injustice. And as I'm sure you all know, the concept has proven very helpful for patients and practitioners in understanding some of the negative dimensions of being ill, having questions ignored, not being able to make yourself be taken seriously. And in the subsequent 10 years, we've tried to expand this project into what we now call the study of pathocentric epistemic injustices. So those which are specific to experiences of illness and healthcare domains. And we've tried to expand this into studying, for example, epistemic injustice in relation to psychiatric illnesses, in relation to healthcare structures, biomedical research systems, healthcare policies, and all as part of a broader project of trying to better understand the whole predicament of patients, because it's clear that there are many different challenges, obstacles, dangers that are built into being ill in this kind of world. And the epistemic injustices are just one kind of the epistemic problems, which are just one kind of the wider set of problems. So it's partly an attempt to try to bring about more epistemically just experiences for ill persons, but also to rethink healthcare institutions and to rethink ultimately what it means to be an ill person in this kind of world. And over time, the project has developed these wider social, political, and then today's topic, global dimensions as well.
Thank you. There's one term that you all have been referencing, and I think we need to put a little bit of definition on, is epistemic injustice. And a second term, we had this in our sort of our pre-roundtable chat, is global health. So can we just move to sort of a little bit of sort of higher level definition work here, and just to sort of, what do you as roundtablers mean by epistemic injustice? Can we get an agreed definition? Because maybe all 57 of us or 60 of us who are here might have an agreed definition. We might have different definitions. Can we get a working definition, or from each of you? I'd start with you, Ian, because, and then go. I'm sorry. Yes. How about you start, Ian, and then we'll go around.
I think it's probably unlikely that we will settle on a single definition. In Miranda Fricker's original characterization, an epistemic injustice, of course, is a wrong done to someone in their capacity as a knower. I mean, I think one useful way to introduce the concept is to emphasize that people have epistemic needs. We need our questions answered. We need to be able to share information. We need to understand our experiences. We need to be able to participate in inquiry. We need to be able to create and share and critically assess information and knowledge. And this is a social and a collaborative process. And when our ability to meet our epistemic needs is frustrated, then people are going to be harmed by this. For example, if you need a piece of information and you don't get it, you will suffer in some kind of way. If you cannot offer your testimonies, it's very likely that your perspectives won't be taken up into practices and activities. So there are many ways that people can be epistemically wronged by individuals, by groups, by structures. And the idea of an epistemic injustice is that some of these epistemic wrongs are products of prejudice, discrimination, unfair exclusion, and those epistemic injustice then will be a subclass of epistemic harms, because there are many ways of being harmed that don't involve injustice. But what I suppose the concept is trying to identify is that class of epistemic harms that are due to discrimination, bias, prejudice, exclusion, the various exclusionary isms, sexism, racism, homophobia, etc. And I think one important question for the discussion today is, to what extent does this focus upon wrongs, injustice, discrimination, etc., reflect moral and political frameworks that are primarily at home in global North moral discourses? Because one important feature of the work on epistemic injustice by scholars in the global South is emphasizing this normative framework is not as universal as some of the work on epistemic injustice tends to suggest. So that's the way I would suggest that we think about epistemic injustices very broadly. It's that class of epistemic wrongs that involve prejudice, discrimination, bias, either as a result of features of individual psychology, or more importantly, as features of historical, social, epistemic systems that have long, messy histories shaped by a variety of broader oppressive ideologies. The obvious one would be colonialism. But that would be my suggestion for a starter.
Anyone else? Himani, do you want to come in?
So I'm coming at it from a global health angle. And if I were to define epistemic injustice in global health, it would be systematic wronging of individuals and entire populations in their capacity as knowers and producers of knowledge, which manifests in, I think these are the terms that we've used before, credibility deficits. So essentially where southern or local expertise is dismissed as anecdotal, unscientific, or just not rigorous enough, and interpretive marginalization where local communities are denied the resources to conceptualize their own health realities in their own terms. And distinctively, I think in my later work, I call them dignitary harms more than just epistemic in nature. Seye, do you want to add something to this definition?
I think Ian sort of went there, and I think you are there as well, Himani, which is that there are that in global health, certainly the way we use it, it's not just to individuals. It could also be, and it often is, about groups of all configurations. And I would roll my definition of global health into what I'm about to say, which is that global health itself is a meeting of unequals. So the parties to a global health engagement are almost by definition unequal. One party has a lot of power and resources and influence. And that power, resources, and influence include epistemic ones. Epistemic power, epistemic resources, epistemic influence. Meeting with the other party with much less. And between whom there's often not just a physical distance, but also a social distance, right? Given the power differential. So that relationship itself cannot not be epistemically fraught. And the things that then happen between those parties, a lot of the problems in that relationship is epistemic. For example, the choice of how to name the problem that is going to be solved, the choice of the problem itself, the framing of its origins and its root causes, the framing of its solutions, etc. I mean, we can just keep going. Those are patterned in ways that serve some interest relative to others by the design of how they are framed and articulated. They're also patterned by the choice of whom to listen to and when and how and to what extent and what gets filtered in and filtered out in that relationship. So there's a lot of epistemic complications in that relationship, a lot of which are unjust.
Rageshri, do you want to come in?
Yeah, so I think a lot about what Fricka says about it's a very human need for us to be able to, produce knowledge, to have it, to interpret it, to be able to pass it on and feel like we've been heard. So when I think about healthcare, I think about epistemic injustice being one of the ways in which healthcare could become dehumanizing for individuals and groups. And kind of just to add, I think, it is something that is perpetrated not just by individuals, but very much by institutions and systems to individuals and groups of people as well.
Linda, do you want to come in?
Yeah, I think I came in at just the right moment. I think I agree with like a lot of what's been said, and there's no difference for me. But I also think about the use of Christy Dodson, and how she extends, the problem of epistemic injustice to how it's not just about testimonial injustice, but there's a sort of smothering and contributory injustice. So there's the knowledge exists, but it's not taken up, and so it's not the problem. The problem is not necessarily that there's a lack of knowledge, but there's this refusal to recognize the knowledge that already exists. And I think one of the panelists has sort of alluded to this. So even when patients are heard, silenced and marginalized, even when patients are heard, their knowledge may not be recognized within the frameworks or the systems that are designed or exist institutionally. Yeah.
I think that this is really, really helpful. I wonder if we, and Seye, you've alluded to this already, I think, and you too, Himani, how we bring epistemic injustice as a kind of framework to this thing called global health. When we're referring to global health, what do you mean by it? I mean, there's I have sort of ideas as an historian, but I'd like to sort of maybe unpack that term as well, and then we can move on to sort of look at some specific ways in which you are actually digging into characterizing the ways in which epistemic injustice is structuring global health in multiple ways. So, Seye, can I ask you to start?
Yeah, global health is a very tricky term. But I will construct a definition that traces its history a little bit from at least the iteration that is dominant today. We would say began with some kind of colonial tropical medicine. And my wife always says, don't say colonial, say invasion. So I would say sort of the invasion of places and peoples and their dispossession, such that the health enterprise served the purpose of helping to not only further that invasion, but also legitimize it. And even in that sentence, you can begin to see how epistemically unjust the enterprise itself is. Because if it's serving the purpose of legitimizing something, it is also saying, here are the ways to frame this thing. Here is how to understand it. And to understand it in ways that take your attention and understanding away from what is really going on. Right. Anyway, and it's changed in its name and behavior and appearance over time. Some people will say it became international health, especially with post-World War II or the immediate. Post-World War II founding of the WHO and having this a global architecture for health, where again The architecture itself is designed to serve certain purposes and to certain ends, which again serve to legitimize certain kinds of behavior and relations among countries in the world, among those that are powerful and less powerful, and again mess up the understanding of what is going on by the words and labels and framings that are used to describe and characterize action. And then fast forward a bit to when we would say we did HIV, which was around when global health itself became the term that was used to describe the thing. And one of the reasons why it became the term to describe the thing was that it was clearer, at least with HIV and AIDS, that it was global. And that all of us were involved in this thing. It affected everybody in very similar ways, which again relaxed, in a sense, the international sense of what global health is. That you could do global health in Boston, within Baltimore, as much as you could do it within Lagos or Nairobi, but also between Boston and Lagos. Right? That it then, in a sense, relaxed how one may see what it means in international terms, which is why earlier I made the point that it's perhaps easiest to think of what global health is in terms of a relationship between unequal partners separated by distance in endeavors that are set up and carried out to reduce or eliminate health inequities in the world with a deep concern for justice. Now, in that definition is the good and the bad, right? But at least we can hold them together.
That's Himani, you mentioned in the pre-chat some sort of the importance of attending to not thinking about global health as something that happens elsewhere. If I may sort of paraphrase, but do you want to come in on that? I may have misrepresented, but
no. So global doesn't exist without the local. That's the thing. So, but unfortunately, or fortunately, or however it is in practice, in a very realist way, I think I'm borrowing a lot from how Shay's already characterized it. But I think it's a field that's got between its progressive rhetoric and its real existing architecture. So it defines itself as this collaborative, equity-driven pursuit of worldwide health. But it operates with this structural division between who holds the power and the powerless, or just people that it's top-down implemented on. So it's a system that's just characterized by distant governance and metrics and success. Everything is dictated by people who define metrics and success. So again, it's not very different from how Seye characterized it. But like I said, it doesn't matter whether, of course, in global health, we use the global north, global south division quite a bit. We use high-income countries, low resource, and all of that. But in local settings, it could just be the same between the patient and a doctor. There are massive power relations and differences in the power relations. So it's who holds the power and who doesn't.
Linda or Rageshri, do you want to come in? You don't have to. I mean, there's no obligation, but if you'd like.
I'd love to come in here because I'm particularly interested in the way that Seye framed it. I think he stole most of everything that I was going to say about global health. But I think, yes, just the way that it's been structured by, like the way that I think of it is that it's been structured, by colonial history that determine whose knowledge is recognized and who is marginalized. And so it structures, like whose knowledge is recognized, which knowledge is dismissed, and I guess then the central thing that I think of, just to wrap up, this thoughts, because I don't think I could extend any more of what Seye has said, but so what comes apparent to me is that the issue is not just unequal health outcomes, but there's unequal epistemic authority, and that's what Himani just kind of spoke about even like the north and the south, the distinctions, but even between patients there's like power dynamics. So I think that's also the kind of critical framing that I would add to that, but just an agreement to what they've said.
Rageshri, go ahead.
Yeah, I can just add very briefly. obviously agree with what's been said before, but I just wanted to add this quote from Professor Madhu Pai, who is a professor of global health in Canada, because I think it encapsulates a lot in one sentence, really. He said that global health is firmly centered on those with power and privilege and focused on their generosity and saviorism. Which I thought encapsulates very neatly, but actually also thinks about the patient-clinician power imbalance as well.
Ian, did you want to come in, or you're good? Good. I mean, one thing that's come up, I mean, I wonder if you could say, any one of you could say a little bit more around, there's this sort of connection between global health and, as Seye has sort of traced, the coloniality of global health and the coloniality of global health knowledge. Is there is there more to be said about that sort of the connection between the sort of the epistemic nature of colonial of global health and colonialism, that those connections, just to unpack this a little bit more. I mean, so for instance, is global health inherently colonial in its nature and its structure? Or have I taken the privilege of being the conveners? I've overstepped my privilege here in asking that question. Shay, you're laughing, so yeah, I'll let you come in.
It's the entanglement that is difficult to disentangle that you entered there. I there's a way one may think of what is colonial. And one of my favorite characterizations of what coloniality or colonization is that it's a substitution of agency or a swapping of agency. That a person group can decide what is good for another person, what another person deserves, what another person know or can know, etc. That it's the taking over of another party's agency. And it's hard to do that. And the things that then follow on from there, which is what we call colonization, it's hard to do that without messing with things at an epistemic level. I either have to be able to convince myself that it's my due right to take over that person's agency, or convince that person that it is my right to take over their agency, or convince a third party that whatever it is I'm doing is fine and okay. And those things are epistemic in nature that then can legitimize and excuse the things that I then do: steal, destroy, kill, etc. So if we then position global health at the heart of part of what allows me, the person taking over the person's agency, to do those three things: convince myself, which is what saviorism often is, that I'm doing good; convince the other person, which is what the kind of imposed inferiority complex that comes with colonization does to the other party. What to convince the third party, which is to say, whatever is going on here is ordained by God or by whatever, or is natural and is normal. Global health in its history helped to do those three things really well. Now, if we then open up the box that is global health itself and say, okay, what's going on inside of here? We would also see versions of that same kind of relationship. Now, is it inherently colonial? Not necessarily so, but as Himani says, it's a field that has strong progressive aspirations. The extent to which you can realize those is a different question. And I think that's part of it, what Himani and I have been engaged in, trying to push the field to. If you want to be this, you have to attend to the epistemic injustices that are at the very core of how you organize and how you function as a field.
Anybody else want to come in on that?
May I, Michael?
Yes, of course.
I mean, I think one useful theme in some of the academic work on epistemic injustice and global health is a sort of pessimistic theme. So I'm thinking here particularly of a couple of papers by Godfrey Tangwa and Dennis Masaka mean, they point out that global health and epistemic injustices tend to serve the interests, particularly of global North health institutions, and particularly, I think Dennis Massacre is the more pessimistic, who emphasizes that given the way that the world is structured, epistemic injustices are vital to global systems of power. And of course, it's a characteristic of the psychology of power that for that reason, people are very reluctant actually in practice to address them because, in very many cases, the process of justice involves, for some people, an unwelcome redistribution of power and resources. I think in those cases, then we should always just think back to Christy Dotson's wise counsel that when we are, as she says, when we are studying epistemic injustices, we have to take care that we do not perpetrate epistemic injustices, either consciously or unself-consciously. And I think for that reason, some of the key themes in the epistemic injustice global health discourses tend to be, well, one is a liberalization of our conception of what health and epistemic injustice and epistemic life are. And then related to that, a strong decentering of our understanding of where the institutional and epistemic centers of power ought to be. Seye, you've written, excellent things on this, but also, much more critically rethinking concepts like inclusion. It's of course very clear that many strategies of inclusion do in fact intentionally or not perpetrate kinds of exclusion, especially if the terms of inclusion are not ones that have been collaboratively developed or that have been informed from, as it were, the bottom up. And I think this would be one of the major methodological challenges for any movement towards a genuinely global, epistemically just healthcare system. Because, of course, one of the deep failings of the world is that an awful lot of harm is done by incompetent efforts to do good. And I think that's going to be a case where thinking about these issues will involve much more philosophical and political and sort of meta-philosophical sensitivity on the part of researchers.
Can I just ask we put some ground some of these concepts that we're discussing here with some examples from the work that you've done? I mean, I can think of, obviously Linda, Rageshri, your work on silencing. Can we sort of we have sort of these very important high-level characterizations of epistemic injustice and global health. Can we concretize? And Seye, your work on antenatal programs in Nigeria as an example. So can we sort of exemplify some of these processes with some examples? So anybody want to take a stab at that? To ground them to get a little bit more granular, I think is the word I'd use. Because this is happening, as it were on the ground. Linda, do you want to speak a little bit about those? You don't have to, sorry. Or Rageshri, do you want to come in with your work on silencing? Because I think there's a lot of tie-ins here that are really, really important. No.
I think I can go after regret. I just want to formulate my thought quickly.
Yeah, I'm going to try and formulate mine as I speak, which is not always a good idea.
Okay.
So I call my book The Medical Practice of Silencing and that really comes from Christy Dotson's work, looking at testimonial smothering and how if you're consistently not listened to or heard, you start to self-censor and not speak up, and thinking about how this silencing happens at individual and much wider levels. And an example I use in my book is the first research I ever did, working in HIV, which was just a very simple survey. We surveyed the women attending our HIV clinic in London for their experiences of intimate partner violence. And we found that more than half of the women attending our clinic had experienced intimate partner violence, which is kind of double the general population. And that kind of went on to inform some national guidelines about screening for it. So, it was a useful research project, but we had huge barriers. So intimate partner violence is a very big driver of HIV infection, particularly for women around the world, but there'd been no evidence on it in the UK. And maybe we didn't need that evidence to write guidelines, but, there was this big evidence gap. And we basically couldn't get the project past ethics. the ethics board felt that we were asking about something that was too sensitive and that perhaps we weren't the right people to do it as HIV clinicians who were women and brown and black. And, you know, I'm glad we managed to get it through ethics, but it really made me think about, you know, why is it that first the barriers that we went through as minoritized researchers to show that we were credible enough to do this research that ended up being important, but also why we had to do it. So, you know, this is knowledge that women living with HIV already had. They knew there were large levels of partner violence, and perhaps, you know, guidelines writers could have listened to them without having this formal research done by academics to show that this was an issue and something that had to be addressed. And it made me, I did a lot of reading about epistemic oppression with Christy Dotson here as well, and thinking about the oppression of women living with HIV and their knowledge when it comes to creating guidance for issues that affect them. So yeah, that's an example, I guess, maybe.
Yeah, great. Thank you. Linda, did you want to come in?
Yeah, so I think I'll just come in terms of, you know, the way that I've framed it in my work. So I've been, I think I alluded to this in like my intro. So I've been looking at how epistemic injustice becomes, you know, visible in, you know, AI systems and mental health care. And the way that I look at it, or that I'm trying to look at it is, you know, the way that, you know, machine learning systems, particularly for mental health care, are developed and trained within the global north and on global north data sets, and on global north biomedical diagnostic categories. And you know, the problem that I try to frame here is that then they're sort of imported or, you know, utilized in like different contexts, like in the global south. And the problem here is an issue of, you know, like context, different patient experiences, different patient understandings, but also when you look at the South African context, you know, patients make use of both the doctors and traditional healers, and so there's a significant role that indigenous knowledge systems like African traditional medicine play within like healthcare for patients, and they offer like very conceptual resources. But when they're imported, they're not sort of operationalized, and so there's this exclusion that this idea that I'm trying to play around with is that the exclusion is sort of like ties in with contributory injustice. It's not that the knowledge is missing, but it's not recognized, and so it becomes, you know, again another structural problem. So that's like the sort of examples that I try to like talk about.
Seye or Himani, do you want to do from your work on, I mean, both the academic sort of global health research, or more specific examples from the antenatal groups in Nigeria, which is a fascinating case study. Do you want to speak to those in any way? Examples?
You want to go first, Himani?
I can give an example from, again, it won't be global governance related. So, an example of data parachuting. So, during the 2014 to 2016 West African Ebola outbreak, immediately after the crisis in West Africa, thousands of biological samples, which is blood and tissue, they were flown out of Sierra Leone and Liberia by foreign military and research institutions. And they were taken primarily to research institutes in Europe and the States. And years later, when again the same scientists who risked their lives to collect these samples, and when the outbreak happened again, they had to literally beg the institutions, the same Western institutions, for access to the sequenced data. And then the resulting breakthroughs and papers from that data that was collected was published in English, and it was published behind paywalls. So this was not just knowledge containment, but it was an extractive division of labor. And that's a classic example of how we characterize epistemic injustice in global health and in those kind of extractive partnership models that we're talking about. But this technically wasn't even a partnership. It was just biological samples taken from a place and then completely made inaccessible to that place. So global health, essentially, a lot of it is built on these kind of extractive relationships.
Thanks. Shay, do you...
Yeah, I'll try and be very quick and give three very quick examples. A quick example is how, for example, the WHO can decide what the standard way of measuring X is. And then it lands in a country, it doesn't make sense. But the country, in order to be part of a global something, has to twist and turn and spend itself in trying to understand itself in that way that it's been told to understand itself. And it messes with understanding. It really messes with understanding of things. The broad range of ways. I won't go into specific examples, but that's an example of how this manifests. The kind of power and authority that frame comes with, regardless of how misaligned it is. Second example is the ways in which we trust and demand randomized control trial evidence for complex social programs. That it cannot make sense except for an audience that does not know what that thing is about. It just cannot make sense. Again, I won't go into the details of the argument as to why it doesn't make sense, but just imagine something that is a moving, multi-component thing that you want to pin down as to whether it works or not once and for all. Something that depends on how people think, respond, modify, adjust, and learn on the go in relation to. Now, that would make sense for paracetamol or a cocktail of anti-cancer drugs that you can relatively standardize. But there's a reason why we want that kind of evidence for complex things, because there's an audience that demands that kind of answer, which papers over people's experiences and abilities to interpret and understand that which is being asked about. The third quick example is when Trump 2.0 happened early last year to global health, USAID, PEPFAR, USAID, people don't, PEPFAR is the US government's AIDS program, rolled back, etc. I found myself unable to explain why I was not very sad. And this took me weeks because I was trying to, because it felt as if there was something wrong with me. Why are you not sad? Or at least why does it feel like heaven is not about to fall? And it took a while. And what helped me make sense of what I was trying to understand was finding this undeservedly obscure analysis of how much per capita spent on health in a low-income country comes from foreign aid. In a low-income country, it's $21 per capita spent on health. Of that 21, 11 comes from foreign aid, 10 comes domestically. In a rich, high-income country like the UK or Australia where I live, it's about $3,000 per capita on health a year. So 21, 3,000, right? Now that 21, 11 comes from outside. Now that 11 is substantial, of course it's more than 50%, but it's nothing in the grand scheme of things. So that if 100 people would die in a country, in such a country, with that $11, maybe 2 less and will die, or 3. So in that country, regardless of all the drama, of all the structure we set up for this thing, 97, 98 people were dying before Trump 2.0 and are dying after. Now, that was how I was able to explain it to my students, because I had to explain how I felt to them, but also more broadly. And again, my reflection was that my inability to explain it, and inability, in my view, of my field to explain what was going on, it is not by accident that we think that those 2 lives equals to the 100. That's everything, because we are trapped in that, and we don't have the epistemic tools to make sense of what it is that we're doing. So again, just that example, which is real for me in the last couple of years, I found as an example of not having the interpretive tools to make sense of something and to communicate. And I promise you, many people around the world in the field are still lacking that tool.
Thank you. Any others want to come in on what's been said thus far? I'm conscious of time. We're at 1 o'clock. And I would really like to pivot a little bit towards addressing or ameliorating problems of epistemic injustice that you've all put forward in your work. Himani, can we start with you, if that's all right? I mean, you've used I think you alluded to this, but the notion of epistemic repair, and also more recently, I think epistemic rights in relation to epistemic injustice is so. I'd just like to sort of, as a way of transitioning towards a conclusion here, because I'm conscious of time. I mean, tackling the conditions and causes of epistemic injustice is probably, we can diagnose, to solve is a huge challenge. And I think all of you have put together proposed ways of trying to address or redress epistemic injustice. So I'm going to hand over to you first, Himani, if that's okay. And your concept of, if whatever, I'm not repair and rights, if you'd like, but as you wish.
All right, so I'll take a quick shot at it first. So one of the ways in mostly philosophical literature, social epistemology, and things where this concept comes from, it's about developing individual corrective virtues. So it's more moral, it's more virtue-based, and it's developing that kind of empathy as a clinician for their patients, for instance, to listen to people and all of that. But then when we're talking about global health, it's structural, it's systematic, it's unequal power relationships at a level where populations, entire populations and groups are involved. And that just cannot really be addressed simply through this developing individual let's say, virtues. It requires something more systematic in place. And that's why I use a dignitary-based framing, because the basis of human rights and human rights law as well, I mean, of course, philosophers disagree on that, but it is human dignity, and it is dignity-based and protection of that. So if we cluster epistemic harms, at least the grave ones, the systematic ones, as epistemic rights, human rights that need to be protected, I think we could then start framing it as more systematic issues that could be addressed at most institutional level. And that was one of the things that I proposed.
Thank you. Rageshri, do you want to come in with because you have a number of really important ways of addressing the question, the challenge of silencing.
So I've tried to look at all the different levels, and it's been a lot of drawing on other people's work, I have to say. But when it comes to thinking about, when it comes to the kind of Himani mentioned about, getting virtue, so doctors listening more, having more empathy. I actually think a lot of it is structural and institutional there as well. So it's less about individual doctors doing better, but how we can create environments in which they can do better and be as they want to be. So whether that's around, building institutions where we have space and time to listen, continuity of care, looking at our training, etc. So I think I just wanted to add on to that is, that it's a lot of that stuff is actually structural as well. And I think that's been a helpful tool of when I've been speaking to clinicians about how we can do better to address epistemic injustice in our practice, is to frame it as being more of a structural institutional thing rather than something that we are blaming them as individuals for doing. So yeah, just wanted to add that one.
Ian, do you want to? You've written quite a bit on questions of epistemic agency and the structural side of things.
Yeah, sure. I mean, I agree with Rageshri that the most important kinds of ameliorative measures are always going to be structural ones. I mean, that there is an important role for the cultivation of individual level virtues of epistemic justice, which Fricker advocated. But of course, it's an important theme in feminist virtue ethics that your capacity to be virtuous depends enormously upon the kind of social environments that you're in. There are many kind of corrupting social environments that try to erode the virtues that we have, or give us a distorted sense of what it means to be, for example, open-minded or just. So there'd have to be the structural reforms. But I think one thing that's understated in the epistemic injustice literature is that many of these epistemic injustices are not just interpersonal and structural, they're also intergenerational. many of these epistemic injustices are parts of complex historical processes that have been unfolding in many cases for centuries. And for that reason, you would need, as it were, different levels of amelioration. There will be individual level, interpersonal, institutional, and structural ones, but also the kinds of cultural changes, for example, that Jake Jackson in the United States writes about, but also these longer intergenerational processes where epistemic injustices constantly, as it were, almost like viruses, evolve and reiterate over time, actively responding to the ameliorative efforts that people have emphasized. And that, of course, means that whatever amelioration is, it's going to have to take lessons, among other things, from the literature on moral progress. So take it that any movement towards a more epistemically just world will be a kind of moral progress. And lately, looking at the moral progress literature, they make clear just how many different kinds of things could count as moral progress and how they would have to unfold and the kinds of resource that you would need. And like thinking about the second stage of Project EPIC, looking at amelioration, I think the key thing to look at then is going to be the range of different forms that epistemic injustice could take, right down from the microaggressive interpersonal epistemic injustices, but also to ones that have been unfolding in different forms across several generations and across national and international boundaries and institutions.
Linda, do you want to come in? You've written about this idea of, or use the concept of epistemic redress, which is slightly different from dignity, or rights. But do you want to say a little bit about your line on this?
Yeah, so that's sort of what I'm working on, and the sort of epistemic redress model that I'm trying to um design it's really rooted in epistemic decolonization. So I use decolonization as a tool. I find decolonization because we've spoken so much about coloniality, right? And I think if we speak about colonization, I think there's a role that decolonization can play here. And sort of what my thinking is in this is like it involves, like in more inclusivity and like meaningful representation in terms of epistemic authority. And the reason I speak about this is because we speak about decolonization, but sometimes it remains sort of rhetorical, but there's not sort of like very meaningful engagement um, with either patients from these marginalized communities or traditional healers. We just sort of, and it leads me to the sort of like decolonization fatigue that I have. So as much as I use decolonization as a tool, I'm almost like fatigued in the sort of like we keep talking about it, but it doesn't seem to be enacted. But essentially, what I'm looking at trying to do here is restructuring the epistemic authority that we've been talking about. Whose knowledge matters at what point, why. So to have more sort of meaningful inclusion for transformation, rethinking what counts as knowledge and who gets to define that. Yeah, and so I think of decolonization, like the objects of decolonization failing if we only include different voices, but we keep the same criteria and we keep um, perpetuating the same sort of cycle. So that's sort of like just in a gist what like I'm trying to do with this sort of epistemic redress model. Um, yeah, it's still in its working stage.
It's fact. No, it's fact. It makes a really important link, I think, between decolonization and epistemic justice. Seye, do you want to come in here?
My head is very much where Ian's comments were, which is first to admit that whatever solutions we have will have to evolve with time and will have to be closely monitored for their failures because very many of them will fail just because, again, the reality adjusts itself to capture. And a very good example of that is how we think and talk about inclusion, for example. That is very easy again. Linda was making that point as well, that you can include a person in a system where the standards and ways of thinking have not changed. Or you can include people at a dose that they can't, in a number that they can't be powerful enough to change the rules that govern the place. And the number and the dose, etc., will have to evolve and change over time. So I often think about what inclusion means and being very critical and careful about how much we expect of it. But also more broadly, because I am a teacher and I know several of the other panelists are teachers, it's also how we teach, especially global health. What we teach people, how we explain things, how we foreground the history of the field, but also the practices of the field, so that things are very clear to people. And these are difficult things to do. And in other words, it's easy to say we educate better, but it's hard. And it's hard for a couple of reasons I'll mention very quickly. One of the reasons is that there aren't enough resources to do the teaching in terms of just intellectual resources. I often struggle to find a clear, crisp, well-explained tool. Again, going back to the epistemic injustice problem itself, right? But the other reason is also that often students come to classroom wanting to be saviors. And how you work with people out of that is rocky. And I've done it enough times to know that you don't get good at it. You just keep trying. So again, changing how deeply entrenched ways of understanding the world and seeing the world, changing it's hard. But try we must.
Thank you. I'm very conscious that we're into the last half hour and we haven't. I mean, there's lots of questions and comments in the chat, and it would be nice to open up the conversation roundtable a little bit because this has been absolutely wonderful. I mean, just as a way to wrap, and I don't know if we can really wrap very, very effectively. What do you envision as sort of the next steps or challenges? I think you've alluded to this, Seye, in terms of teaching, but others might. You have sort of some reflections on where this work on epistemic injustice in healthcare and in global health might be going. What are the next challenges ahead? And then we'll open up to discussion. Oh, I silenced everybody with that question. Or shall we just move to questions? What would you like?
Ian has a smile on his face.
Yes, he's going to come in. Ian.
I was saying we should move to questions.
Okay, we shall move to questions. We'll open it up to chat. I agree. Sorry, that was a bit of a so I've asked if you have a question, please, you can raising your hand because there's so many people might be a bit of a challenge. But just indicate in the chat and then unmute yourself if you have a question for the panel or you want to make a comment. There's lots of comments here, but it would be very helpful if does anybody have a question or comment? I'm trying to go through the.
Jamie is raising his hand.
Oh, great. Thank you. Sorry, Jamie. I'm trying to multitask and
sorry, I couldn't
for your health. Go ahead, Jamie.
The chat.
Thank you, Seye.
I do have a question. I just want to take Seye back to the beginning. I was really interested in your earlier point about the overlap between epistemic injustice and colonization. And I was wondering if you could specify how you define or decide what counts as epistemic injustice and colonization, and by implication where they don't overlap. I'm particularly interested in hierarchies of knowledge or how populations are framed, categorized and measured by policy or through RCTs. Yeah, some clarification around that would be really helpful. Thanks.
Thank you. There is a very popular paper by Tuck and Yang that sort of warns against using decolonization as a metaphor. I use it as a metaphor. So I'm saying this to people who care deeply about the paper that I'm going to offend their sensibilities. There's a way in which we may use what is colonial as a metaphor and describe a lot of what we would call epistemically unjust as colonial. right? Which was the point I was making when I said the substitution of agency, right? Or the things that manifest in that way. It could be along lines of gender or class or race, etc. Things that may not align with how we understand colonization to have functioned. But again, I try to separate the examples you gave, Jamie, sort of the use of RCTs and the way that it's used, the ways of categorizing people as things that would occur, that occur or that occurred, regardless of colonization, the territorial colonization as we know it. There are things that are properties of how power functions in society, how things are classified often in hierarchies, even when the initial classification was not intended to be hierarchical, etc. So there are things, the epistemic practices that sit outside of what we may deem to be colonial, especially in a non-metaphorical way of defining or describing what is colonial.
Jamie, would you like to come back? Or you?
Yeah, I mean, yeah, thanks, Seye. I guess it's I get confused about that overlap, and I suppose I think about, rightly or wrongly, colonization as based in medical histories of diagnosis, categorization, measurement, predictability, generalization that have been, applied globally and institutionally embedded within how we decide what problems to measure and tackle through evaluation designs like RCTs that categorize, measure, predict, generalize in particular ways, and are used, as we know, to use that evidence widely without really thinking through very carefully what context is. So for me, that functions as colonizing. But I'm just conscious of this debate about, well, that isn't necessarily colonization. That might embed in epistemic injustices, but that isn't necessarily colonization. So I'm just confused actually about where that overlap is and isn't. So I'm interested in different perspectives on that.
Thank you. Corey Bradley, you're next up.
Absolutely. Thank you so much. I woke up late. I'm here in the US, and the only thing I wanted this whole week was to participate here. So I'm happy to know that there's going to be a recording. Seye, great to see you, and thank you. I hope I don't bore you with this question because I've talked with Seye and read his work and also had conversations, but don't want to miss the opportunity to ask folks if they have insights. I do what's called implementation science or implementation research, and the particular tact that I have evolved based on a lot of really fantastic and phenomenal work, including work of folks in this call, has been thinking about centering and re-ontologizing implementation science from its focus on the study of methods to make use of evidence-based research and evidence-based findings into routine practice, to thinking about how do we think about it in the context of epistemic justice, because within that definition that it has to be evidence-based, already there's a whole group of practices. I work with community-based organizations who do things, who are only required to do what has been approved through as or designated as evidence-based. So anyway, that's just one example of how I think epistemic injustice happens. And then this notion of just marching people technocratically to modernity. So because it's an evidence-based finding, it has to be implemented, and it doesn't pay attention as much to context and social realities. That's my framing. If folks are not familiar with implementation science, but I'd like to know, if you are, how you think about epistemic injustice or the practices and things that we could do to do that within the context of implementation research.
Does anybody want to? That's a tough one.
Fair. It's pretty big. I left it really broad for folks just in case. If you have anything, I'll take a sliver of light. Anything you have there.
Any thoughts?
Can I have one thought on this, Michael?
Yes, go for it.
Thanks, Corey. I put a link to one of your relevant papers in the chat. I think one point to emphasize is that I think there is sometimes a sense in epistemic injustice studies work in philosophy that, as it were, we're the first folks to start doing this kind of work. But as many people, including Christy Dotson, have emphasized, there are long generations of people, theoreticians, activists, and activist theoreticians who've been doing this sort of work from the grassroots for a long time, and that there's a huge amount that academic epistemic injustice studies should take from those people. I mean, partly because reinventing the wheel is a needless task in a time when resources for many folks are very scarce. But also, of course, there would just be a terrible irony in trying to develop strategies of assistance for people who've been developing strategies of assistance and resistance for themselves for an awfully long time. And I've seen your paper, you reference Jose Medina's Epistemology Resistance book. And, Jose makes this point very eloquently, as he does actually in his most recent book, which I think is called the Epistemic Activism on the Epistemology of Protest. So that's one general thing I'd say. The people studying this are not necessarily always the people who have been experiencing this. And that's a methodological point that if you're wondering what do we do, a lot of people have been asking that question, not out of mere curiosity, for a long time.
Is that good? Okay.
I could maybe add just something.
Oh, come, please. Yes.
Yeah. So I've got a chapter in my book on objectivity and our kind of the way that we rely on objectivity and looking at kind of the hierarchy of medical evidence and how it's all, at the top of all the quantitative methods and how, those methods that foreground patient voice, like qualitative research, methodologies that use more patient involvement have always been undervalued and aren't published and therefore may not make what is deemed to be good evidence for implementation science. So I think it's around, how do we increase kind of patient involvement, public involvement in research, looking at diversifying our research methodologies and valuing them better.
Yes, lovely. I agree wholeheartedly. I think this emphasis in implementation research in a participatory approach, whether that's with external communities or folks within a given health system, I think is a possible way to democratize science and get behind the scenes and tinker with different policies and practices and bring them into a more equitable light. Thank you so much.
Thanks. That's great. We have a question from Ben Smart, who can't unmute, so I'm going to read it. I'm curious how the panel think epistemic harms might weigh against other forms of harm. For example, perhaps a specific culturally valued traditional treatment might be provably harmful to health on average, or at least less effective than mainstream medicine. Banning the harmful practice might cause epistemic harm, but would arguably not be an injustice. But there may be cases where the mainstream treatment is just more effective. I guess the question is, epistemic and physical harms seem very different. In rare cases, in rare cases where there's a tension, how do we weigh them up? I'll restate that because I gobbled it. Epistemic and physical harms seem very different. In rare cases, when there's a tension, how do we weigh them up?
Can I speak? Sorry to speak again, but I
just
think about this.
No apologies.
This happens every day in my clinic where, I may be advising people to take antiretroviral medication or medication that I can prescribe, for example, and people will come in and say, well, I also want to take this kind of homeopathy or something that hasn't gone through trials. And we have these conversations all the time, and it's often, I'm not going to object to you taking this because it hasn't been through an RCT. We can't prove that it is effective. But, for you may have knowledge of it before. You may know from people in your community that this is something that is going to be helpful for you. So I'm always like, please take the medication that we know from trials is effective and safe, but you can also take the homeopathy or the indigenous medicine that you've been recommended as well, if it's not going to cause harm. So I think, there's a lot of discussion to be had there for me, individual patients about trying to, it's more of an and, I guess, than a either or is what I try to bring into consultations.
Is that Ben? Oh, go ahead, come, please.
If I can jump in quickly.
Yeah.
It depends very much on how the determination of effectiveness has been made. what we think effectiveness means in this scenario. And there are scenarios where there is a very clear and simple sense of effectiveness that we can judge very simply. It won't be the case for in many other circumstances where the path to effectiveness can escape a lot of people's understanding. And it will be wise to be slow to reach a judgment, including the judgment that leads to a decision to ban. And even when something is as bad as one wants to ban it, it's also how you go about the banning. You can ban in a way that is not epistemically harmful. You can ban in a way that is epistemically harmful. So there's a lot going on in that question. And again, I'm thinking, for example, and this is not a treatment per se, but FGM is something that we should ban, or should not happen at all. But how you go about doing it can be harmful or not. In the same way that how you go about banning a therapy that may be ineffective can be harmful or not.
Rageshri, did you want to come back on that? Because you see, go ahead. Sorry, I interrupted.
No, and I think it's about creating dialogue, isn't it? So I think, I talk a lot about, people not wanting to take vaccinations because of not trusting where they come from, being experimented on, lots of very reasonable reasons for not wanting to be vaccinated. But, my initial response has been, why wouldn't you want a vaccine? So, it's very easy to shut people down and to silence them. But actually, by listening to them, taking their concerns very seriously, you can create a dialogue where they can bring you information that they've heard, then you can exchange it with information that you have. So I think as you said, it's about being slow, isn't it? It's about creating that dialogue so you can both respect each other's views, and hopefully that power is then more equal. And you can still say, I don't think this is a good idea, or I think you should have a vaccination, but it can be done in a less, as you say, epistemically harmful way, I think.
Linda, you had your hand up. I saw.
Yeah,
And
I
Himani,
did.
yeah.
I think there's not much I can add from what both Rageshri and Cheyenne have said, but I think because my work focuses a lot on like mental health, I think that this dialogue is there's more space for this dialogue to happen, especially if we think about the way that patients with depression and anxiety respond to different interventions. And so I think that like what would be considered harmful, like one person would say, well, you would need to go on antidepressants or see a biomedical practitioner, that sort of thing, whereas patients find meaning and help in different kinds of interventions. And I think that's why dialogue is so important, because I think we assume we know what is best for patients and we don't engage meaningfully with patients. And I guess that kind of goes back to I think it was Ian who said, in trying to address epistemic injustice, that we don't, like reinforce the injustice itself. So that's kind of the idea that I had. So yes, I don't know if it fully addresses Ben's question. I know he and I go back and forth with this, because he's my supervisor. But yeah, I think I've just gotten some really interesting ideas from this. Yeah.
Thank you. That's great. Himani.
So Michael, I think this is something that you've also been working on, vaccine hesitancy from a historical perspective, but I'm just going to give a very short sort of response to this. I think we cannot separate physical harm from epistemic harm because they're structurally codependent. So when you see mainstream medicine, it encounters a traditional practice that it deems less effective or harmful. The instinctive reaction, of course, of top-down global health governance is to issue a paternalistic ban. So on paper, it looks like a clear victory for physical health, but in reality, it almost always backfires. So when you ban a culturally embedded practice without understanding the knowledge system behind it, I think you don't just erase that behavior, but you simply drive it underground. And that's the same thing with bans on pretty much everything that's like alcohol, tobacco, so on and so forth. So most dangerously, what you completely destroy is then the structural trust that is between the community and the healthcare system. And once that trust is broken, I think there's a kind of a chain reaction to other physical harms. So people stop showing up to other clinics. They hide their illnesses. They resist future health interventions such as vaccines. And I think, Michael, that's the one that you've worked on. So yes, I don't think you can completely separate the two. That would be my short response.
I think that's just a wonderful tie-in to the overall theme of the roundtable, and a nice, we're at time, and a nice way to end, if that's okay. I mean, if I just, before we do that, is there anything that the roundtable folks have that we haven't touched on that you would have liked to have raised? Is there any sort of things that we haven't touched on that you feel you'd like to sort of flag up before we end? We've covered a lot of rich, important, dense ground. But if there's anything, if there isn't, I can't tell you. Is there something? No, good. I can't tell you how wonderful this has been, and how much certainly myself and I think the EPIC team appreciate the time that you've taken to share your thoughts and your experiences and your insights. It's a really, really important area of conversation, and this has been a wonderful contribution. So I really, really just want to thank all the panelists. So if you can do a virtual clap, thumbs up, or whatever to everybody. It's a lot of work, and I know some people like Seye I mean, it must be like 11 o'clock in in Australia. So much appreciated. Um, and yeah, for those of you who want to listen to this again, it will be posted on the EPIC webpage. Please have a look at our project if you haven't already. But for now, thank you so much.
Thank you, everyone.
Thanks, everyone.
Thank you.